For the nice introduction. I'm very happy to be here again in this very nice place for a conference. And I want to talk about something more practical in the daily life. So I was asked to talk about problems when blood glucose is different from hemoglobin A1c. First, we talk about the diagnosis. The diagnosis of diabetes mellitus is rather clear. There are clinical signs, a lot of clinical signs. This is from an American textbook. And all these signs are true, particularly for type 1 diabetes. And you see for type 2 diabetes is only drink a lot, eat a lot, blurry vision, and a lot of urine. So this is, sounds not very specific. If you think of these big German beer parties and the beer tents, then you have also this drink a lot, blurry vision, and go to the toilet a lot. So it's not very specific. We need some of the laboratory. In the American Diabetes Association Commission, they decided to have hemoglobin A1c larger than 6.5 is the best screening laboratory parameter, in addition to all the glucose parameter, the conventional one. We know this for a long time. However, is glucose an old horse for the diagnosis of diabetes mellitus? I show you that it is not, hopefully. Just one case, diagnosis of diabetes mellitus only by hemoglobin A1c. From the internet, I learned that a 27-year-old female American reported that an hemoglobin A1c of 7.6% was found during a health checkup. The young lady, now with the diagnosis diabetes mellitus, was treated with daily insulin injections. After 1 year, she said, she moved to another city and visiting another doctor, she was told not having diabetes, but rather being very healthy. How could that be? Hemoglobin A1c 7.6 is clearly diabetic. Do you have any idea? She didn't say mistake, but she said the other doctor did an extensive anamnesis, and the lady mentioned that her spleen was removed after an accident. So the spleen, which is important for the removal of the red blood cell, so this changes the hemoglobin A1c. No insulin, the lady was healthy, and she was very upset and posted it, of course, in the internet, this mistake. The basic question, if you don't know, if you're unsure what is right or what is wrong, is the question, is the hemoglobin A1c technically analytical, any pre-analytical, any error? Or is the value right? So the measurement, everything is okay, but the interpretation is wrong. What is hemoglobin A1c? Again, it is an addition of glucose to the beta chain of hemoglobin, which is stable, and this can be measured. So again, we should emphasize hemoglobin A1c is still a hemoglobin, not glucose. Sometimes there are equations, but we think this is not good. It is proportional to the glucose concentration, that's what we want to know, but also proportionally to the red blood cell lifespan. All the other parameters, for example, fructosamine, that's very similar, of course, but it's not hemoglobin, but it's more albumin in the plasma. Now, another case from my colleague from Jena. They had diagnosed a patient, 52 years, and this patient was visited the ambulance since more than 20 years. And it was type 1 diabetes, treated with insulin, no complication, dermatitis herpetiformis, gliadin antibodies, and there was no change, and there was just a normal, regular treatment. What happened? What is the problem? This is the protocol of the glucose, hemoglobin and glucose values. And it was clear that this patient was pretty good in metabolic control, 6.5 hemoglobin, but at the sudden there was a drop of the hemoglobin A1c, but no change in the blood glucose. Blood glucose was always below 150 milligram per deciliter. What happened? They were very unsure what could be, and the hemoglobin A1c in the laboratory was analyzed again with the same value. That was about 3.5. Something happened here, and they looked at the protocols, and this patient was treated with dapsone, and it turned out, when looking exactly to the blood analysis, they realized that there was 10% less hemoglobin, hematocrit, and red blood cells in the report. This colleague told me that they looked in the literature, and it was till then it was unknown to him and also to me. That's why I show it to you, that a lot of drugs can cause hemolytic anemia, because by either induction directly by the drug or in combination to develop antibody. That's not very uncommon, and that's why you don't realize that the red blood cell may be lowered or even not lowered, but the turnover may be increased. And this may happen if you look at the list of drugs. These are normal drugs also used and given to diabetic patients. Just another case in our laboratory, in our clinic. A male diabetic patient, rather old one, type 1 diabetes, 6 years, so it's for LADA, was sent to the clinic. The son was a doctor, and he said, "Father, you should go to the clinic to improve your metabolic control." So he came to the clinic, to the ward and ambulance, and the hemoglobin A1c was 9, measured by the DCA, which is a small point of care testing apparatus, but in the central laboratory it was 6, so that's really discrepant. And the fasting plasma glucose was around 250. It seems that one would guess that this hemoglobin A1c is right, and the other one is wrong. It was repeated, the central laboratory. Most of the doctors think central laboratory may be better. But in this case, we were asked, and this is the list over 6 months, just to tell you, all of them went down, all of them, but the discrepancy between these two hemoglobin methods, they stayed. How would you proceed if there is a clear discrepancy between hemoglobin A1c and glucose measurements, and they could be repeated? So it's not an analytical problem or pre-analytical. Forget about the hemoglobin A1c, because it fits, and accept the DCA value, it's better fitting to the blood glucose, or send it to another laboratory for the analysis, discuss the problem with the laboratory, or request a fructosamine assay. Any suggestions? The easiest way is to start to ask the laboratory which kind of method do you apply, and then you can discuss first and then go on with others. And they did that, and we analyzed afterwards. We analyzed because the chromatograph system we use in the lab, this is the hemoglobin A1c, and this patient had a double band. So there's something wrong with the hemoglobin A1c, with the hemoglobin. And then we did an hemoglobin analysis and find that there was abnormal hemoglobin in the different shells, and in the DNA sequence there was also clearly substitution of one lysine 66, unknown till then, and it was clear that this patient not from Africa or from Arabic countries where they have a lot of mutations, but also just a normal patient. And he didn't know then till then, of course, but hemoglobin A1c analysis by chromatography was wrong, and not by the immuno method, which is used by the point-of-care testing. What is the difference? The difference is can be explained by how the antibodies are generated for the immunological method, which is used mostly now in Europe and also in America. The antibody has been generated against the last 6 amino acids of the beta hemoglobin chain, which is glycated. And the antibody recognizes only this, but not the unglycated one. You can generate this because you can split here with a specific enzyme, and then you have only the hexapeptide, 6 amino acid, and this is the immunological procedure, and this is also the reference method for the detection and quantification of hemoglobin A1c. So which method is better? Which one is right if you have a problem? You cannot say this really. The immunological method is less subject to interference because the antibody recognizes only these first 6 amino acids which are glycated. So if there are any mutations along the long chain of hemoglobin, the beta chain and the alpha chain, of course, then it should not be interfered. On the other hand, the hemoglobin pathology or mutation may not only interfere with the analysis, but lead to change in erythrocytes' lifespan, like in sickle cell hemoglobin. And then you can see that in the chromatographic procedure, but not in the immunological one. So it's not easy if you have the chance in the clinic to have both methods like we have. If you have any doubt that the hemoglobin A1c may not be right, go to the other method, like we did those days. And if not, then measure, in addition to the blood glucose, fructosamine assay, which is rather easy and not very expensive. Now, what about the biological variation? People are different, and the hemoglobin A1c is also different, and we do have influence factors. Influence means they're influenced by the individual and not by the analysis procedure. And this is clearly the age. It's increasing 0.1% hemoglobin A1c per decade, and it's usually not integrated in the reference values. Clearly the genes, particularly African Americans in America, it was seen very early that they have 0.4% hemoglobin A1c higher in reference. What about gender? Female individuals do have lower hemoglobin, total hemoglobin, but in percentage, hemoglobin A1c is the same reference value. And pregnancy, it's a problem. We cannot really use hemoglobin A1c for diagnosis of gestational diabetes because hemoglobin A1c during pregnancy is U-shaped. It's higher and then lower during pregnancy and goes up at the end of the pregnancy. So hemoglobin A1c is not allowed for diagnosis of GDM. And very early on, it has been shown by twin studies that about 50% of the hemoglobin A1c variation is due to genetic background in healthy people. Are there other influence factors? One influence factor which is usually not recognized is that the turnover of red blood cells is decreasing if a diabetic patient is in bad metabolic control. So the red blood cell survival is decreasing This is about 15 hemoglobin A1c, so very bad control, and then it is 1/3 lower. So actually, the hemoglobin A1c that gives you in your interpretation that the patient is not good in metabolic control, but actually it's even worse. If you measure the blood glucose, you can see that. In addition, hemoglobin A1c cannot be used in uremic patients, diabetic nephropathy, which is an important part of our patients, because the hemoglobin A1c underestimates the glycemia. This Japanese group has a lot of papers, and that's one of the first, and they show that hemoglobin A1c 7.0, which is a rather fair metabolic control, which you would interpret as rather good metabolic control, corresponds to about 250 milligram per deciliter glucose. To emphasize this even more, I found a review which analyzed the results of 56,000 diabetic nephropathic patients, and they found that nearly half, 40%, of these patients do have hemoglobin A1c values below 6, though actually for diagnosis they would not have diabetes. And most of them have would be in very good controls. Only these some percentages they have elevated, and they do have diabetic nephropathy end stage, and they mostly are on dialysis. So this is an important influence factor, and the measurement of hemoglobin A1c is right. So the turnover has changed. And a colleague showed me this own results from his laboratory, and he found that hemoglobin, or the other way around, reticulocyte count of more than 32 per mil, if that is higher, then he didn't find any elevated hemoglobin A1c. So with the new formation of erythrocytes, if this is increased as measured by the reticulocytes, then the hemoglobin A1c, of course, is lowered and normalized because the turnover is faster. We do not have any method in the routine laboratory, and also for science it's very difficult to measure the turnover of red blood cells. In earlier times, in the 60s, they labeled with radioactive substances the own erythrocytes and give it back, but this is not allowed in these days. So summing up, the biological influence that is not a laboratory error in what I said before, but this is biological, and this has to be interpreted by the doctor or even known before. So the gender, the age, the gender, there's really no difference. Alcohol consumption and smoking, there's a little influence, but particularly all forms of anemia, iron deficit, and the treatment then may induce the de novo synthesis, and then the hemoglobin A1c is actually going down. I told you the hemodialysis problem, bad metabolic control, genes in Afro-American, severe liver disease, and I should add also that some drugs, or a lot of drugs, may induce hemolysis. To show you which one is better for metabolic control, glucose or hemoglobin A1c, the interference factors and influence factors, I showed here the list, and you clearly can see by just looking at this slide that none of them is completely with no mistakes, but they substitute each other. Here hemoglobin A1c is not influenced, but glucose, and here it's the other way around. So we will have glucose and hemoglobin A1c for diagnosis and metabolic controls in the next years. And we changed in Germany the guidelines that we do not have hemoglobin A1c as first screening parameter for diabetes, but rather reintroduced the old-fashioned glucose. And if there's any problem afterwards, you can use the tolerance test or hemoglobin A1c. And the Americans, in the meantime, in the new guidelines late last year, they changed the order. Hemoglobin A1c is now not in the American suggestion at the first place. Without saying anything, they put it from they put it from the first place down to the third place. Although it's or. You can of course, as physician, you can choose what where you start. But in the text, they say with hemoglobin A1c, you should be cautious because there are a lot of influence factors, mutations may occur, and then glucose is the better parameter. So the take-home message is we have an analytical variability. The best thing is if you have doubts that you ask the laboratory, talk to them. Biological variabilities, and this is the hemoglobin A1c, the relatively broad reference values are, this range is relatively broad, that was clear all the time, but this is hereditary and it's independent of glucose. There are genes and mutations known, and of course age, ethnic background, and influence factors, of course the lifespan, kidney disease and cirrhosis, anemia and treatment, and drugs, that's what I said. Check hematological parameters. So if there is an anemia or any change in red blood cell count, and look at the de novo synthesis of fructosamine. So glucose is not yet an old horse, and thank you for being invited here.
Thank you very much, Professor Steiner, for the good messages in our clinical practice. I would say that the first days of discovering of HbA1c, the medical community believed that we don't need to use the measurement of blood glucose, both fasting or postprandial. Of course, in our days, we use both in order to see how is the glucose control. And of course, you told in the last that the same value of HbA1c does not give data for the variation of the blood glucose. Of course, we have, the main problem will be for the next lecture, what is the meaning of have the diagnosis of diabetes mellitus just having the value of HbA1c. But I would like to wait and Professor Peter and to have some questions both for the two presenters. Professor Stein, thank you.